Even though we include the scoring guide, we find that sometimes people will go through the training and they'll just go ahead and start to take the test. And we really want to make sure that you pay attention to some of these scoring rules, or you're going to end up taking the test over and over again. So you might ask me, especially again my seasoned colleagues, why all these rules? Well, the reason is if we don't impart some rules for scoring, we'll never be reliable. So novice clinicians have a much easier time with this. I think it's just harder when you've been doing one thing the same way the whole time. So we like to make it a little easier for you so it's not frustrating. It's not meant to be easy, by the way. If we're going to be assessing such an important issue as swallowing that affects a patient's safety and survival, it's really important that we do this right. So I'm going to give you a few scoring tips to think about as you're watching the training, and certainly reflect back on these before you go in and take the test. And also look at the scoring guide. It's there for you. So I would like to just review a couple of things about when and where to make your visual judgment or your score. This is really important for reliability. So a couple of key spots. When you're looking at component 2, for example, bolus hold, be sure to make your judgment prior to the first productive tongue movement to propel the bolus through the oral cavity. Once the tongue starts moving, you're on to component 4. So bolus hold before productive movement of the tongue. With mastication, you're making your score as you're chewing the bolus. Don't think about the movement of the tongue at this point. Even though tongue movement is integrated into mastication, keep your focus on the efficiency of the mastication or the chewing movement. With component number 4, bolus transport lingual motion, make your judgment as the tongue is moving back. So productive movement of the tongue. Initiation of the pharyngeal swallow, people have some difficulty with this, but if you keep your eye on the time of the first brisk superior anterior hyoid trajectory, that will cue you as to make your judgment. So you're looking at the relationship between the head of the bolus and that first brisk movement. It's very difficult to separate anterior superior hyoid movement because they move as a trajectory, not these discrete movements. Component number 8, it's very important that you apply your score when the epiglottis reaches its horizontal position. We know from the literature that as the larynx elevates, the epiglottis assumes a horizontal position. So that's what we use as the point in time to make our assessment of arytenoid to epiglottic base contact. This comes from work by Ole Ekberg, comes from work by Pete Carrillis, etc. So it's very important that you score when the epiglottis is horizontal. However, if the epiglottis doesn't even get to horizontal, you would score approximation of the arytenoid to the epiglottic base as a surrogate for laryngeal elevation at the point where the epiglottis maximally distends. And that may not be very far, and it may not even be to horizontal. I'd like to clarify some terminology. When I refer to height of the swallow as a marker of when to make your judgment or your score, what I'm referring to is maximal displacement of the anterior hyoid bone. So when it moves its maximal anterior direction, that's the height of the swallow. You would score anterior hyoid excursion, of course, at the height of the swallow. You also score laryngeal vestibular closure. That is complete closure of the laryngeal vestibule at the time when the hyoid is maximally displaced anteriorly. For these other structural displacement scores, you make your judgment and apply your score at the point of maximal movement of that particular structure. So For rating soft palate elevation and retraction, you go to the video frame where the soft palate's maximally elevated and retracted. Epiglottic inversion, the point of maximal inversion. And that may be just horizontal because it may not fully invert. In fact, it may not even be horizontal. But you go to the point of maximal displacement of that structure, and that's your score. Pharyngoesophageal segment opening would be the point of maximal opening. Tongue base retraction, the point of maximal posterior word movement of the base of tongue toward the posterior pharyngeal wall. Pharyngeal stripping wave, component 12, you have to make your observation as the posterior pharyngeal wall progresses superiorly to inferiorly along the tail of the bolus. So you should start to see, in a normal circumstance, a thickening of the posterior pharyngeal wall superiorly, and then there's the middle constrictors engage, and so the thickening progresses to the mid-pharynx all the way to the inferior constrictor. As far as lip closure is concerned, you can score this at any point in the swallow, really, during the time you're containing it, but your lips should really be closed throughout the swallow. So if you're losing material from the oral cavity, even when the bolus is in the pharynx, I would score it throughout the duration of the swallow. Oral residue, pharyngeal residue, of course, as you know, you score them after the swallow. You make your score after the initial swallow. You always score after the initial swallow, your judgment, with the exception of the sequential swallow task. With the sequential swallow task for residue, I would make a judgment of residue after the final swallow, because sequential swallow is the task. They're not isolated individual swallows. For components 13 and component 17, you score them in the anterior-posterior viewing plane. As you begin to score, I want to just review a few things that tend to confuse people. So I want to show you where the first anterior hyoid trajectory is to assist you with component number 6, initiation of the pharyngeal swallow. So I'm going to walk you through this. So you see the material is in the mouth, the patient's holding it in the front. You actually see that they've lost some of the bolus here on lip closure. So if I was scoring component number 1, I would say that we are a 3 because this extends beyond the vermilion border. And so let's go to hyoid. I'm going to go forward here. Just watch me. So the material's in the mouth, the patient's moving the bolus through the oral cavity, so I'd be assessing lingual motion. The head of the bolus is already here, right? So it's at the tongue base, and the hyoid hasn't moved yet. So I'm going to keep my cursor on the hyoid to demonstrate the movement of the hyoid before initiation of the pharyngeal swallow. Not moved yet. Head of the bolus is here. It's actually looking like it's moving down a little bit, and you'll see that sometimes, but it has not moved forward. And if I was going to select when it moves forward, its first anterior movement, I'd pick right here. Right there. It goes beyond my cursor. And the head of the bolus at that point in time is beyond the vallecula. It's mid-pharynx. That's a score of 2 for initiation of the pharyngeal swallow. This is residue from the previous swallow, so don't be confused. So again, onset of the hyoid is right here. Goes beyond my arrow, starting the anterior movement, head of the bolus, beyond the epiglottis, not yet to the piriform sinus, score of 2. Another area that seems to give clinicians some problems is being able to recognize when the epiglottis is in its horizontal position. And again, this is critical for judgment of component number 8, laryngeal elevation, because you make your assessment of laryngeal elevation based on the surrogate of arytenoid to epiglottic pedial contact at the point when the epiglottis is horizontal, because we know when the epiglottis is horizontal, that's a sign that the larynx has elevated. So I'm going to take you to the beginning of this swallow and advance forward and mark that spot for you. Okay, so I want you to notice that the epiglottis is still upright, right? The head of the bolus is already in the pharynx. The head of the bolus is past the epiglottis, which is still upright. So the swallow has yet to trigger, the pharyngeal swallow. Head of the bolus is here. The swallow has triggered because you see the anterior movement of the hyoid, but the epiglottis is still up. There's the tip. Bolus is flowing over. And at this point, the epiglottis is horizontal. Some of the tip is still up, but the body of the epiglottis is horizontal. So I'll back it up. Next frame. And if I was scoring component 8 right now, I do not see complete approximation of the arytenoid cartilage here to the epiglottic petiole. In fact, I see a big air space here. And that's a sign that the larynx hasn't lifted and potentially the pharynx hasn't shortened because the pharynx participates in lifting. That would be a score of 1. So partial superior movement of the thyroid cartilage based on the surrogate of approximation of the arytenoid to the epiglottic petiole. There's certainly movement. They go from rest, but it's partial at the point of horizontal epiglottic movement. So let's take a moment to review where the height of the swallow would actually be. So I'm going to put my eyes on the hyoid bone, and we're going to track the hyoid forward, right? And you see the hyoid movement. So the thing to remember is that when you're looking at some of these maximal displacement or height of the swallow, they last a couple of video frames. So you're just trying to find the point at which it doesn't go any further. So after this point, it doesn't go any further. So this is where I would make my judgment of, and for component number 9, anterior hyoid. At this point, when the hyoid is maximally displaced, this is where I would also judge laryngeal vestibular closure. So I'm looking for any contrast, air or barium, in the laryngeal vestibule. But I wouldn't make this judgment as the larynx is elevating. I would make it at the height of the swallow. As far as soft palate elevation and retraction is concerned, back it up. Here's your soft palate up here. So we're going to take it to its point of maximal contraction. And you see here this sort of knuckle-like configuration, maximally contracted, posterior pharyngeal wall abuts it. This is where I would make my assessment. For epiglottic inversion, if I'm going to the point of maximal displacement, here's my epiglottis. Let's advance it forward, forward. Here it is past horizontal, it's bending. Maximal displacement is right here and it's fully inverted. See that? Okay, PE segment opening. Right here. I'm going to take the point of maximal opening. Here it's starting to open. This is the point where it's maximally open. So I would make my judgment here. And tongue base retraction. Here's the base of the tongue, the point of maximal displacement where I would make my score. I'm going to follow it, follow it, follow it, follow it. And here you see a gap. So the tongue base, the configuration or contour is here. Here's the posterior pharyngeal wall here. Now as we follow this back, you're going to see that it does not come all the way back to the posterior pharyngeal wall. You have a gap. So find the frame where it doesn't go any further, and that's where you're going to make your judgment. As you start your scoring practice, I really want to caution you to take a look at the scoring specific guidelines. These are developed for you to help you. First of all, there's a scoring guide. Look at pages 5 through 11. And we also have some really amazing component help files my wonderful colleague Kate Humphreys has devised. And so what these are some very specific examples of challenges that people have had throughout the training. And again, one of the most important contributions for me with the MBSImP is to keep this a fluid process that continually improves based on field testing and feedback from you. So let's do some guided practice on some difficult cases. I'm not going to take simple ones, but these are the ones we get calls about, so we're just going to put them out there to help you. It might surprise you to learn that some of the most difficult components to score are actually the oral components. It surprised me at first, but this is held true from the very beginning. And when you stop and think about it, however, and you think about the variation, the variability in what people do with material in their mouth, it does make sense that it would be the toughest to try and standardize in terms of your visual judgments. So the first one that gives people a challenge is tongue control during bolus hold. And recall from earlier discussions that you make this judgment after the patient is cued, whether they understand it or not, to hold the bolus in the oral cavity. And you notice that during the protocol, when you're actually doing the exam, this is a very quick time. You don't, sit there and radiate them forever while they're holding it in their mouth. As soon as they demonstrate to you they can hold it, then you say swallow. When you're doing the training, you should assume that once you see fluoro, we have given them the command to swallow. We can't record voice in order to be HIPAA compliant, so you should just assume that they have been given the prompt to hold it in their mouth before you give them the command to swallow. So let's look at this example. I'm going to play it through. So watch the swallow in its entirety. And I will go back now. Makes it a little challenging because this patient has his head slightly back. But you can see clearly at the onset of the exam, immediately after he's told to hold it in his mouth, before the tongue starts to move, the bolus head leaves the oral cavity and falls into the pharynx. As you can see right here. So the head of the bolus is already into the vallecula. So the material's fallen through the mouth. Now he's moving his tongue, initiates a swallow. And this is a score of 2, posterior escape of less than half of the bolus from the oral cavity during the time you've told them to hold the material in the mouth prior to the initiation of productive tongue movement. Now I'm going to show you another challenging case, and this is component number 4, bolus transport lingual motion. You see a more viscous bolus in the oral cavity. This is a honey type consistency, and what you're going to just observe in real time here. Okay, so what you'll notice is this particular patient holds the bolus at the very beginning anteriorly, so almost in the floor of mouth. So this is kind of a dipper sort of swallow, that the patient kind of dips the tongue to move the bolus back. Jerry Dodds talked about tippers versus dippers. Most of us are tippers, but when patients hold, a normal variation is holding the bolus anteriorly and really behind the inferior incisors, and then dipping the tongue up to push the bolus back. So he does do that. But once he starts to move the bolus back, he's getting a grip on it, it progresses in a productive anterior-posterior motion, but it's somewhat slow. It's not repetitive, and you can see residual in the oral cavity, certainly signaling that there's probably some issue with the strength, the pressure generation of the tongue. But that's what I would judge as slow, and that would be a score of 2, slowed tongue movement. In order to be classified as repetitive disorganized, the rule of thumb is it has to be 3 or greater repetitive back and forth motions of the tongue and bolus before you're going to score it repetitive disorganized. People often overcall this, and if there's just a slight movement in the tongue as they acclimate to the bolus being in the mouth, they're calling it repetitive disorganized. That's not what we're going after here. We're going after this, problem with initiating the motor program where they're pumping the tongue and the bolus back and forth. So 3 or greater is going to bring you to a 3. Initiation of the pharyngeal swallow is another challenging component for some people, and I've made a big point already about making sure that you're looking at the relationship of the location of the bolus head at the time of the brisk anterior superior hyoid trajectory. So let's take a look. You're assessing component number 6, initiation. This is real time, slow motion. And I think it's pretty clear that the head of the bolus is in the vallecula, does not go beyond the vallecula here at the point when the hyoid begins its brisk excursion. There goes the hyoid. Okay, so it's already moving. Head of the bolus is in the vallecula, and there goes the hyoid. And that would be a score of 1, bolus head in the vallecula. If the head of the bolus leaves the vallecula and is anywhere between where the vallecula ends and the piriform sinus start, the top, then that's going to be a score of 2, and that's in the region of the hypopharynx, and we say posterior laryngeal surface of the epiglottis. Unfortunately, many clinicians neglect to do the anterior posterior view. It takes work. You have to reposition the patient. Clearly, you can't test everyone based on their physical condition, cognitive condition, but many times, if you're diligent, you can get a good exam. If you look at this particular patient, this is the mandible here, and if you can ask the patient to slightly elevate the head, you don't want it extended back, but just at a neutral position, you get a really nice view of the pharynx. And so what you're looking at here, these are the lateral walls. This is right, this is left, and if you've done this a long time like I have, you can kind of see that this left wall looks like it's a little further away from the cartilage than this side. You may or may not be able to perceive that. It does appear that there's more filling and of the piriform on the left at rest, and it's a little wider. So that's going to give me a few cues as a clinician. So don't focus so much on the bolus, focus on the movement. So I'm looking for lifting of the walls and compression of the walls on the bolus tail. So let's watch in regular motion. And now slow motion. Bolus comes over the back of the tongue. Larynx lifts, and compresses. And you see over here that you get outpouching of the pharyngeal wall on this side. This patient has a really interesting looking epiglottis. It's that omega shaped, really thick. You can see it really well. I don't know if you're used to looking at an epiglottis, but it's right there and it's thick, which is very difficult on videostroboscopic exams, I might add. And if you're looking again at the height of the movement, which is what you want to look at here, you're going to see this outpouching of the pharynx on the left side. And then you do also see residue. So this would be a score of 2, unilateral pharyngeal bulging.